Okay, I think we can start. Uh, Welcome everyone for another session of the AAP section of Neonatal Perinatal Medicine and TCAN Virtual Journal Club for the 52 and 52 RCT challenge for it. So today we're going to talk about higher or lower hemoglobin transfusion thresholds for preterm infants from the paper in NEJM in 2020. Today's mentors, it's a pleasure to introduce Dr. Ravi Mangal Patel and Dr. Harish Kriplani. And a presenter to us today would be Dr. Anti Valagala. She's a neonatal fellow at Yale. For it, I'm Viral Jain. I'll be your moderator and host for today. For it, just some ground rules. During the presentation, the mentors can interrupt anytime they feel there's any teaching point for it. If the audience have any questions, feel free to send me a direct chat, and we'll address this question at the end of the session for it. So starting first, let me introduce Dr. Ravi Mangal Patel. Dr. Patel is an associate professor of pediatrics at Emory University and Children's Healthcare of Atlanta. He's also the PI in the NICHD Neonatal Research Network, an executive committee member of the American Academy of Pediatrics. He's also the member of the section on neonatal perinatal medicine and also chairs the International Society of Evidence-Based Neonatology, or the EBNEO. He is a foremost expert and has research interest in NEC and neonatal transfusion. We're very glad to have Ravi here today. Next is Dr. Harish Kriplani, who also needs no introduction. He's the professor emeritus of pediatrics at McMaster University. He's the founding director of the Infant Chronic Lung Program at CHOP. He has been funded by the NIH and the Canadian Institute of Health Research for various multinational trials, and was the PI to Neonatal Research Network of NICHD at UPenn with Dr. Barbara Schmidt. He also served as the editorial founding board of EBNEO. He has been involved with various RCTs in the NICU since 1995 and has done many famous trials such as HiFi, inhaled nitric oxide trial, the SAIL, and the Pint trials, which changed the way we practice neonatal medicine. He's also the foremost expert in evidence-based medicine in neonatal trials. So we are very lucky to have Dr. Patel and Dr. Kriplani, the EBNEO experts, help us today with our presentation. With that, I'm going to have Anti lead the presentation. She should be able to share her slides now.
Great. Thank you, Dr. G. Yeah.
While she shares, I'm going to share a poll for everyone to answer, which we'll discuss at the end of it. So Anti, give a minute for the poll and then we can start on my queue.
Okay. I think unfortunately the poll is in the way.
Okay, you can just minimize it. Sure.
Okay. Can you see my slides okay?
Yes, we can.
Okay.
They look great.
Okay. Great. So thank you, everyone. I'm Suganthini Valagala, and I'm one of the neonatology fellows at Yale. Thank you again for giving me this opportunity to present today. I have no disclosures before I start my presentation. So the article that was picked today was higher or lower hemoglobin threshold for preterm infants. And this was done by Dr. Harish Kriplani, who's very kindly moderating our session today, along with Dr. Ravi Patel. This was published in the New England Journal of Medicine in 2020. So as I review the article, I will be going through the consort checklist for reporting randomized trials, and I'll highlight these checklist items which are included in the article. The next 2 slides looks at the different checklist items in each section. So you have the title and abstract, the introduction, the methods, the results, as well as the discussion. So before I start to review the article, I just wanted to take some time to discuss the pathophysiology of anemia in these preterm infants, talk a little bit about the benefits and the risk of transfusion, and explore why there really is a wide variation in transfusion practices from a global perspective. So looking at anemia in preterm infants, we know that there is a wide variety of roles that play into their development. And I do want to take a brief pause here and just acknowledge that the etiology of neonatal anemia is very broad, very complex, and unfortunately I can't address all of those categories, but I do want to mention that of course we have a whole host of causes such as obstetric causes, internal hemorrhages and bleeding in the newborn period, and the hereditary red blood cell disorders, as well as the autoimmune and acquired causes. But I do want to focus on specifically an anemia of prematurity. So I've listed some key causes here. And some would comment that perhaps one of the key contributors is that immaturity as well as impaired erythropoiesis. So we know that erythropoietin is a primary driver for synthesis of hemoglobin in preterm infants. And then when you do have that initial increase in oxygen content, which is often triggered when you have this developmental switch from hemoglobin F to the lower hemoglobin affinity A, has a much better oxygen delivery to tissues. So when you have that combination of increased blood oxygen content as well as increased tissue oxygenation delivery, you would have a downregulation of the erythropoietin and perhaps a temporary suppression of erythropoiesis as well. So the diagram here highlights the hematopoiesis in the fetus and also in the neonate. And we see that it's in a constant state of flux. So we see that when it does come to fetal erythropoiesis, it happens in 3 different sites. So you have your yolk sac, your liver, and your bone marrow. Unlike the term infant, the fetal or the early preterm infant, the erythropoiesis happens mainly in the liver, which is much less sensitive to perhaps anemia and tissue hypoxia. And this could lead to a relatively decreased response to erythropoietin production to that preterm infant's falling hemoglobin. Another key contributor is the reduced red blood cell lifespan. So we know that the average cell survival for newborn infants is about 60 to 80 days, but perhaps this is much less with decreasing gestational age, and it can be as low as 45 to 50 days in extremely low birth weight infants. And that reduced red cell lifespan could also contribute to the severity of anemia. We also see that iron stores are depleted, especially with preterm infants having a rapid growth rate and also having increased utilization and missing that important intrauterine iron transfer in the 3rd trimester. And this could also contribute to anemia as well. And I really want to highlight this iatrogenic and almost non-physiological cause of anemia is frequent blood sampling in the NICU. So we know that especially in the first few postnatal weeks, these infants are very sick and have pretty severe cardiorespiratory illnesses, and they often have pretty intensive schedules when it comes to lab testings. And there have been studies which have looked at the volume of blood samples, and it can vary anywhere between 8 to 35 cc's per kilo in the first few weeks of life. And so this could really exacerbate that gradual decline in hemoglobin levels as well. So we see there is a wide variety of factors that contribute to anemia of prematurity, and the decision to transfuse is really often carefully weighed. But despite this, transfusion practices vary. And I want to highlight this study here from Dahlman, and this data is fairly old, and it has been seen and from the 70s. So from a historical perspective, perhaps clinicians have recognized that both term and preterm infants do have a progressive decline in their hemoglobin in the first 8 to 10 weeks. But we see this is not really the case. So especially looking at the graphs here, so on the x-axis, you can see the hemoglobin in grams per deciliter, and in the y-axis, you see the age in terms of months. You also see 3 separate graphs for your preterm infants who weigh between 1,000 to 1,500 grams, those who weigh between 1,500 to 2,000 grams, and the term infants who weigh over 3 kilos. So among those term infants, you see that your hemoglobin values fall from between 14 to 22 all the way down to 10 to 12. And after reaching that nadir, the values gradually increase and eventually perhaps reach adult hemoglobin values within the first 2 years of birth. But in preterm infants, this is not the case. You can see it's much more profound as well as it's more rapid. And even in the absence of having no phlebotomy or no laboratory testing, these infants actually experience a much more rapid and severe anemia and often reach a nadir as low as 7 to 8 grams per deciliter much earlier. And these low values are seen in the smallest and least mature preterm infants. So a point that we should definitely take into consideration as we consider transfusion in our infant. So this data is from a much more recent study, and it was an international survey, which was a web-based survey, and it was distributed to neonatologists all over the world in 22 countries. And they were from the States, from Europe, as well as South America. And you can see there is a wide variation, especially in the first week of life. So each box here again, so along the x-axis, you have the hemoglobin, and then on the y-axis, it talks about the different forms of respiratory support, varying from no support to mechanical ventilation. And each box represents the interquartile range between the 25th to 75th centile, and the median value intersects each box. And in that first week of life, there's a wide range of distribution in transfusion thresholds in infants who don't require any respiratory support, and full mechanical ventilation compared with the thresholds in the second, third, and fourth weeks of life. So we see that these thresholds for transfusion vary, and perhaps this is because the evidence for transfusion is limited. So I want to take a brief pause and then talk a little bit about the benefits and the harms of transfusion, and research is still ongoing. So talking about perhaps the benefits is one of the key components, oxygen delivery. So we think that with hemoglobin, it plays a very important role in the transport of oxygen to and from lungs. And the rate of your oxygen delivery does depend on your cardiac output, as well as the oxygen carrying capacity of your blood. So as the infant becomes much more anemic, you have this gradually declining oxygen carrying capacity. And it gets initially compensated when you have a high cardiac output and tissue oxygen extraction, but with much more rapid losses, and if you have increased phlebotomy for the infant, as well as severe anemia, one might argue that this actually eventually exceeds those existing compensatory mechanisms and lead to perhaps end organ tissue hypoxemia and resulting in end organ dysfunctional injury. There have been some studies, especially looking at using NIRS, looking at an association between red blood cell transfusion and enhanced cerebral, abdominal, and renal tissue oxygenation. However, some would argue perhaps this could be a surrogate outcome, and clinical correlates are not clear. Another key benefit that's often discussed in the literature is reduction of apneas. So there has been a randomized controlled trial from Iowa, specifically looking at research by Bell and his colleagues, and they did report that there was less apneic episodes following red cell transfusion. But in contrast, there are some retrospective studies from a group from Germany by Westkamp and his group, and they looked at preterm infants who weighed less than 1 kilo, and they didn't show that these red cell transfusion improved apneic episodes, nor the level of respiratory support or bradycardic episodes as well. And then similarly, there was a study that looked at administering fluids and not transfusion of blood products, which decrease apnea. So really the evidence is conflicting and it's ongoing. And then finally, from a benefit standpoint, I want to talk about weight gain. And again, this is also unclear, and there is conflicting evidence where some groups do report that there was an improvement in weight gain, whereas others don't. And then finally, talking a little bit more about risks, and there's a whole host of risks that has been mentioned in the literature, and I'll highlight some of the key risks here. So one thing that, during review of the literature that did come up was transfusion of associated infection. So we know that this has decreased pretty dramatically since the 90s, and it's currently very low because blood product providers have adopted much more rigorous guidelines, and especially when we're concerned about transmission of CMV, we know that using perhaps leukodepleted and CMV seronegative blood transfusions actually prevents this from occurring. And another key risk perhaps could be iron overload. And one thing I do want to touch on is necrotizing enterocolitis as well. There have been some concerns that have raised in the last few years that perhaps there's a possible increased risk of NEC among these transfused infants. So to date, this is pretty unclear and often multifactorial. There have been mice studies that have done looking at transfusion triggered NEC in bowel injury in anemic mice, but didn't necessarily cause any harm. And that severity of bowel injury is perhaps related to the degree and the duration of anemia, which kind of really accentuated that inflammatory changes in the intestine. Similarly, there has been a meta-analysis of 11 case control studies, which looked at a higher weekly risk of necrotizing enterocolitis with infants with severe anemia than those who are not anemic. And there is ongoing research in terms of clarifying this. I'd like to take a moment here and then ask Dr. Patel and Dr. Kapilani if you could add whether there are any further benefits or harms in regards to transfusion.
So virtually all of the things that we talk about of significance for babies, very preterm babies, has been putatively associated to anemia or transfusion. So that applies to intraventricular hemorrhage and also retinopathy of prematurity. The weight gain in particular was something that drove the early neonatologists from a very important observational paper from Stockley and Oski. But there's been very little data to confirm that. I have my views about NEC, and we'll perhaps discuss those at the end. But that's about it, I think, unless there's something specific, Anthi.
No, that's it. That's perfect. Thank you so much. So moving on, so we know that research is ongoing in looking at the risks and benefits of transfusion. And I really wanted to highlight this very important key trial that led to the work that I'm going to be discussing later on. So this is the Pint trial, and specifically talking about the post hoc analysis of the Pint trial. And Dr. Kapilani, please feel free to interrupt me at any point. This study looked at over 450 extremely low birth weight infants who are less than 31 weeks. It was a multi-center randomized controlled trial, and it looked to test two outcomes with two different hemoglobin thresholds, so restrictive versus liberal. The primary outcomes included death, retinopathy of prematurity more than grade 2, bronchopulmonary dysplasia, and brain injury. And what they found was that the primary outcomes was experienced by about 74% in the low threshold group and 69.7% in the high threshold group. But there was no difference or no statistical difference between the two in regards to primary outcome. But what's interesting is that a post hoc analysis that was done over a two-year period following that, when they specifically looked at the composite outcome of death as well as neurodevelopmental impairment, where it was defined as one standard deviation below the mean, so i.e. the mean being 100 and one standard deviation being 85, they did suggest that there was perhaps a moderate cognitive benefit at about 18 to 21 months of age. And since this was a post-hoc analysis and wasn't pre-specified, it really led to a lot of the work that I'm going to be talking about later on. Anything else you'd like to add there?
I think you nicely highlight that, that this post hoc analysis is kind of hypothesis generating, which is, I think, the way in which it's probably the most appropriate to view this as, this is an interesting finding, and not settling on it as this is certain, but that it should be tested as Harish did in a much bigger study designed for the specific outcome, as I think you'll touch on.
Right. Thank you. So around the time that this article, this trial was being designed, there were two key trials here. So the Iowa trial by Bell and his colleagues, and also the Pint trial, and the Aetna trial actually happened much later, but I wanted to kind of highlight these different trials that really help us guide our transfusion practices. So the Iowa trial at the time, you can see compared to the Pint trial, had a slightly smaller number of infants who were enrolled. Their birth weights were similar. However, specifically looking at their transfusion outcomes, these weren't pre-specified in the Iowa trial, whereas in the Pint trial, it was. Looking at the restrictive and the liberal transfusion threshold, they're very similar from the upper levels as well as the lower levels, as well as the liberal levels as well. And what's interesting here, that specifically looking at the IY trial, they did comment about the impact of brain injury, so especially severe grade 3 and grade 4 IVH, as well as PVL, and neurological outcomes. And they did report that initially, especially in the restrictive arm, they had a higher rate, whereas the Pint trial noted a non-significant trend towards the lower neurological morbidities. Also from their follow-up data, they did talk about performing cranial ultrasounds on day 7, but did not perhaps talk about the timing of the IVH or the risk factors of IVH, such as delayed cord clamping or hypotension or the use of vasopressors. And in their long-term neurodevelopmental outcome, they actually showed that the liberal transfusion group performed significantly worse in terms of reading, visual memory, as well as verbal fluency. But their data was limited because a lot of their patients were lost to follow-up, and there was a disproportionate number of males in their follow-up as well.
Harish, you'd like to say something?
Yes.
Antti, can I just amplify that? I think that's quite an important point that you just ended on. And let me explain what I think is the issue here. The primary outcome of the Iowa trial was number of transfusions. So in many ways, you can argue it's a self-fulfilling prophecy, right? If you have a liberal intervention, you're going to, if you're following the algorithm, you're per se going to translate into statistically significant more transfusions. It's implicit. The outcome of IVH, they did quite a number of post hoc evaluations and came up with a conglomerate. So that's a little bit of an issue. It could be considered hypothesis generating, but it's got to be flagged. As for the longer term afterthought, this is a problem in my view, because they had about 51% attrition bias. You really cannot make anything of their very, very tentative conclusion that there was a worsening of MRI findings in the group with liberal. So at the end of the day, as Anthi is saying, we were left with an interpretational problem in the field.
Right, absolutely. Thank you. So moving on, so this is the current trial, the top trial. So I want to talk a little bit about the PCOT for this. So this was a very well designed, open, multi-center, randomized control trial. The population of the infants that was looked at, they weighed less than 1,000 grams, and the gestational age varied from 22 to 28 plus 6 weeks. And these infants had a postnatal age of 48 hours or less who were able to participate in the trial. So the intervention was higher hemoglobin threshold, and the comparison was lower hemoglobin threshold. The primary outcome was a composite outcome, and it looked at death and cognitive outcome as per the Bayley scale. And the neurodevelopmental impairment was defined as either having cognitive delay, moderate or severe cerebral palsy, severe vision, or hearing loss as well. And cognitive delay here was identified as having a cognitive score of less than 85, i.e. 1 standard deviation below the mean of 100 on the Bayley scales. And these infants were followed up to 22 to 26 months of age. So looking at the Consort 2010 checklist, the abstract clearly identified this as a randomized controlled trial. It was very clear, transparent, and sufficiently detailed. And there was a structured summary of the trial design, methods, results, as well as conclusions. Moving on to the methods. So the infants underwent randomization between December of 2012 and April of 2017, and they were followed up until February of 2020. And this was a prospective recruitment, which really adds strength to this randomized controlled trial, allowing for accurate data collection. The exclusion criteria was also very well detailed and mentioned in the methods. And this included those infants who were non-viable, infants who had congenital cyanotic heart disease, parents who had a hemoglobinopathy or a congenital anemia, parents who'd opposed or wouldn't give consent, as well as infants who had in utero transfusion, as well as twin-to-twin transfusion syndrome. In terms of exclusion criteria for the follow-up assessment, they also mentioned that infants who were going to receive or plan to receive erythropoietin or had a congenital condition or had an adverse outcome which is going to affect their long-term outcome were also excluded.
So, Dr. Kulplani, you have designed multiple trials over your career. This is probably one of your biggest trials. So how difficult was it for you to recruit all the 41 NICUs and get people interested in this question?
I think because we had shown that there is a variable practice, people, despite their biases, because everyone has biases, was willing to be able to buy into this pragmatic trial. It was interesting that in the Pint trial, which was a little bit more difficult to do, because at that stage, people weren't thinking about this at all. It was partly driven by my frustration at the bedside with repetitive arguments about when to transfuse, but also the demonstration of the adult trials, the TRIC trial in adult intensive care that demonstrated that perhaps there was a deleterious issue with transfusion that allowed, I think, our neonatal community to understand that actually we didn't have a definitive answer and that it was worth doing this. So it was difficult, but over time became less so. And I think I've got to say that the willingness of the NRN to engage on this was quite important. And I think the German network found exactly the same when you talk to Axel. The importance of the group willing to come together to answer difficult questions was key. Is that answering your question, Viral, or was there something else?
Yep, that was very informative. Thank you, Dr. Kulplani. Antti, you can take over.
Okay, thank you. So in addition, both the primary outcomes and the secondary outcomes were also pre-specified. In terms of the secondary outcomes, there was a very well-detailed analysis of the composite cognitive, language, and motor scores on the Bayley scales. In addition, the trial also looked at survival to initial hospital discharge without severe complication, which is a very important outcome when we think about considering high versus low transfusion thresholds. And in terms of the secondary outcomes, it specifically looked at other comorbidities, which included grade 3 to 4 IVH, PVL, ROP more than stage 3, bronchopulmonary dysplasia, stage 2 or 3 neck. The infants, like anthropometric measures such as the weight and length, as well as the last use of caffeine therapy as well. So it's a very well detailed, extensive analyses in terms of the secondary outcomes. In addition, to help with the trial, they also had 4 authors from the Neonatal Research Network who helped with the coordination, monitoring, data collection, management, as well as analysis. And they were responsible for the integrity of the data as well as the accuracy of the data analysis. At each site, it was ensured that the IRB was approved, and they also had written informed consent from the parent or the legal guardian of each child. In addition, I do want to add here that there was independent oversight was provided for the data from the Neonatal Research Network as well, all adding to the strengths of the trial that was designed. So following from this, I wanted to highlight the intervention algorithm. So the team made sure that they did adhere to their ethical recommendations. And when determining the different transfusion thresholds, this was done according to their postnatal age, as well as their requirement for respiratory support. So we can see here that in week 1, it's highest in the first week of life, much lower in each of the 2 successive weeks, and then stable thereafter. And respiratory support in this trial was defined as mechanical ventilation, CPAP, requirement of oxygen of greater than 35%, as well as requiring nasal cannula of 1 liter per minute. So at this point, given that this is a pragmatic and a practical trial, the clinicians were allowed to deviate from this algorithm, especially for specific reasons. So for example, if the infant had unanticipated bleeding or there was anticipated bleeding during the surgery, There were concerns for severe hypoxemia, hypotension, or sepsis. All of the transfusions were recorded and centrally reviewed with the algorithms. And if they were inconsistent, there were seen to be deviations. And I will talk a little bit more about the deviation rate when I talk about the discussion of the article. Hi, Dr. Harshia.
Anthony, can I just interject one thing? This was actually probably one of the most difficult things for us to come down on. And it's very similar to the Pint algorithm. And we had a lot of discussion about whether to broaden the range, both going higher and going lower. We held the line for a couple of reasons. There'd recently been a large trial, it was the ARDS-NET trial on ARDS, where people had amplified the ranges of end expiratory pressure. It was a very important trial because it was the first trial that demonstrated a reduction in mortality in adults with ARDS. It came under very severe fire for going beyond the ethical boundary of what was considered then routine practice. So I felt that we just couldn't move beyond the ranges that we had identified and had been recommended by bodies. So again, as part of a pragmatic trial to get buy-in at the bedside, regardless of whether the site was in the neonatal research network, at the end of the day, it lives or dies on whether or not clinicians are prepared to submit their infant patient and approach the parents for consent to randomize.
Absolutely. Thank you for that. That was super informative. So talking further about the methods and also the randomization process, this was also very well done. So the infants were randomly assigned in a 1-to-1 ratio, either to the higher or lower threshold group. And this was performed centrally by telephone with the data coordinating center. And this was then further stratified according to their birth weight. So infants who weighed less than 750 grams and those who weighed between 750 to 1,000 grams, as well as their trial center. And I do want to inform that, of course, this was a pragmatic and a practical trial, and blinding at the bedside by the clinicians were not performed. However, it was performed in all other aspects. So for example, all the follow-up examiners, so the psychologists, the psychometrists were unaware of this and underwent unaware of the intervention. So in terms of the sample size, I want to highlight that they estimated 1824 infants and a 10% loss to follow-up. And the way this was generated was, it was reported that in the neonatal research network between 2005 and 2008, there was a 52% incidence of death or neurodevelopmental impairment. And I assumed that perhaps the outcome rate would be similar in their intervention group. So approximately about 54% in the lower threshold group and then 47% in the higher threshold group. And they had an overall conservative event rate of 50% in both treatment groups. So they then, using this, estimated that a sample of 1,824 infants with a 10% loss to follow-up would have an 80% power to detect the absolute difference of 7 percentage points in the incidence of the primary outcome. And this would then give a type 1 error rate of 0.05, which really adds to the power of the trial as well. Finally, I wanted to talk a little bit about the interim monitoring in regards to the methods. So the independent data, they wanted to ensure that they had safety monitoring throughout the data at different time points, because the primary outcome was only available at 22 or 26 months of follow-up. So they were able to collect data at 4 different intervals. So this is when they had 25% recruitment, 50%, and then 75%. And they specifically focused on a composite outcome of death, necrotizing enterocolitis, as well as adverse findings on head ultrasound. And regardless of the interim monitoring, the overall type 1 error rate was 0.05. So it didn't affect the overall power of the trial as well.
Could I make maybe a question to Harish about, you pointed out that this was one of the, the larger trials in our field, and the trade-off of, kind of choosing parameters for your sample size that are realistic, but kind of capture an important effect. I wonder if you could comment on how you settled on these decisions about where to target, and the difference you're looking for, and what power to choose.
So when making these decisions, everybody, I think, on the call understands it's a bit of a trade-off. I mean, had we gone for a 90% power, obviously we would have had a much more larger sample size, and the feasibility of doing that would be at jeopardy. So we thought that this absolute difference was clinically meaningful, and that was the starting point. On top of the starting point of what the pilot data had shown, both from the post hoc analysis of the Pint trial, which really highlighted that there could be a meaningful difference in Bailey outcomes at 18 to 24 months. So it became an issue. And as Anthony says, we can't easily monitor for safety or indeed for benefit in such a way if it's a 2-year outcome. And that's why we built that set of interim monitoring criteria. In particular, I think it's fair to say that the community was very angsted about necrotizing enterocolitis. So that's why we built those short-term outcomes for the DMC to look at. It's not perfect, but it's the only possible solution if your primary outcome is indeed at long-term. And we felt it was very, very important to do the long-term as the primary outcome. Does that address the question, Ravi?
That was great.
Thank you. So looking at the statistical analysis of this trial, the primary outcome was analyzed using robust Poisson regression to ensure they had adjusted relative risks and 95% confidence intervals. The binary secondary outcomes, including the red cell transfusions, were also analyzed using Poisson. And then linear regression was used for the number of transfusions received. And then Cox proportional hazard survival regression was used for other secondary outcomes, such as time to regain birth weight and then time to full enteral feeding. So I do want to take a minute and talk a little bit more about, so we know that in terms of baseline characteristics, so especially gender and socioeconomic status, could be implicated and could potentially be crucial confounders in their cognitive outcomes among survivors in follow-up. So one of the things that they wanted to kind of stratify is that to ensure that they had suitable interaction terms to ensure they have consistency of treatment effect. And there was a subgroup analysis that was performed, and in this instant, the data was further stratified according to their birth weight, their center, as well as their gender as well. There was no pre-specified plan to adjust for multiplicity of testing for the secondary outcomes, but p-value was only reported for the primary outcome with, as we all know, p-value being significant for less than 0.05. And the analyses was conducted all using the SAS software. And again, this was a very robust analysis from a statistical standpoint. So really, in terms of the methods, the trial really hit all the checklist items, as well as the randomization, implementation, and the methods. And I just want to very briefly mention, and also Dr. Patel and Dr. Kripalani, we talked about it in our pre-meeting discussion as well. So yes, there was a small part just in terms of their blinding that it was not possible at bedside, but those who assessed and performed the psychological assessment after the follow-up were all blinded. And I'd just like to take a moment to kind of talk about that a little bit more and get your input on that as well.
So obviously it would be great if you can blind your sort of intervention. So usually that's easiest done, for instance, if it's a drug that you can easily find a true placebo. But once you start getting into ICUs with big machines and electronic things that make dings and bings, it's very difficult to do. And you can't easily nor ethically blind the transfusion. And indeed, the parents knew exactly when their baby was being transfused. The key thing then is to try and minimize any bias, is to make sure that you have a provision for blinding the outcome assessment. And that's what we tried to do.
Great, thank you. So looking at the results a little bit further, the paper did include a participant flow diagram, and I do apologize, the numbers are very small. But what I really wanted to highlight here was that in total, 4,915 infants were screened for being eligible, and out of them, 1,824 infants underwent randomization. And the primary outcome data was available for 1,692 infants, which is about 93%. And what this really highlights was that there was excellent follow-up data, which really minimizes your attrition bias and really adds to the power of the study as well. So looking at the neonatal and maternal characteristics of their baseline, so both groups had very similar characteristics. So in terms of the higher versus the lower, they had very similar birth weights, similar gestational age, similar gender distribution, as well as in terms of the singleton pregnancy. And I want to focus a little bit more about the maternal characteristics. So in terms of the racial characteristics, the race was reported by the biologic mother on their child's birth certificate. So we can see there is a pretty equal distribution when it came to the Black and the white population. However, in terms of the other ethnicities, the numbers were slightly smaller. So at this point, one might consider that perhaps if there is a smaller number of population in there, would the treatment effect could be extrapolated to that group. And I think we did talk about this briefly in our pre-discussion meeting, is that it's depending on the population that you serve, you want to make sure that they are generalizable to each of that population. Is there anything else that you'd like to add here? So looking at the results, so specifically looking at the primary composite outcomes at 2 years, so there are two key outcomes here. So one was death and the other was neurodevelopmental impairment. And we can see here that the outcomes were very similar. So it was 50.1% in the higher hemoglobin threshold, and then 49.8% in the lower hemoglobin threshold. And this was not statistically significant. And further looking at the breakdown of the primary outcomes, whether it's death or neurodevelopmental impairment, there was again no significant difference between these outcomes. In addition, similar results were also obtained when they performed post hoc sensitivity analyses as well.
Could I make one comment on about that?
Yeah, of course, yeah.
Just to highlight, looking at, we're used to looking at p-values, but I also would say, and this is one of the, you don't see this very often, having a trial with a large sample sizes, you have a relative amount of precision around that relative risk. And so the overall relative risk was 1.00, but you also, the 95% confidence interval is relatively narrow, and that allows you some sense of, what the potential benefit or harm would be, kind of the ranges, as opposed to a trial where you had the same relative risk, but your confidence interval spanned 0.5 to 2, for example. And I think it's always good to just make a comment or note about that. Is one of the benefits of larger trials is power, but also precision in your kind of estimate of treatment effect.
Absolutely, thank you for that. That was really informative. And then in regards to your pre-specified secondary outcomes, again, it was very similar in both groups in terms of survival to discharge without severe complications. So again, 28.5% in the higher hemoglobin threshold group, and then 30.9% in the lower hemoglobin threshold. And again, the adjusted relative risk was not statistically significant either. And this is again seen further in the neurological impairments in regards to severe cerebral palsy, as well as requirement of a shunt, microcephaly, and seizure disorder. And then when developmental delay was further broken down, whether it's composite language score, motor score, or cognitive score, it also showed that the incidence was very similar in both groups. However, there was no statistical difference. So looking at the results, the checklist, again, this trial was very well analyzed and it met all the checklist items in the CONSORT 2010 checklist. So in summary, and then the trial concluded that a high hemoglobin threshold did not improve survival without any neurodevelopmental impairment at 22 to 26 months of age. And it's interesting because the Pint post hoc analysis previously had suggested perhaps there was a moderate cognitive benefit at about 18 to 21 months in the infants who were assigned to the higher hemoglobin threshold. However, the difference was that was a post hoc analysis. And again, the top trial had a much larger number of infants and therefore had a better power. It was similar to the results that was seen in the randomized control trial looking at erythropoietin for neuroprotection in preterm infants, again showing there was no significant difference in terms of neurodevelopmental outcome. And again, I want to kind of mention here, there were other trials that were performed in Europe as well as North America. So specifically the trial that was done in Germany, which was the ETNO trial. And they also looked at a large group of infants, but slightly smaller than the top trial. And they also specifically looked at death and neurodevelopmental impairment as well. And they also found no significant difference at that time. And it's interesting because there has been a meta-analysis looking at both liberal as well as restrictive transfusions, but this was published before the top trial as well as the ETNO trial. And they found a trend perhaps towards reduced ultrasound detected brain injury, but overall no significant difference in terms of adverse outcomes such as death, ROP, bronchopulmonary dysplasia, and necrotizing enterocolitis. And the fact that there were similar outcomes in both singular trials as well as meta-analysis really highlights that these results were generalizable.
So, Dr. Kriplani, a question for you. You informed us that you chose the lower threshold values to be more pragmatic, so there's more adherence to the trial. But with the robust results of this trial, do you think we can go lower than the restrictive values you have set with the data we have right now?
Yeah, the absolute scientist would say that you have to stay within those ranges because that's what we know. And frankly, as an ex-clinician, I can't pretend that I'm making these decisions any longer. I would also say that I think it's pretty risky going lower than that. So I think that the problem then becomes, are you then at a threshold where your information to give to the parents has to invoke risk? And I think that's the case because you're then into the boundaries of potential underperfusion. And I think that before extrapolating lower, we would need more information to do that. And I certainly wouldn't be comfortable in doing that because I think that the worry is always that you will actually precipitate underperfusion or hypoxemia. So I'll leave it at that for now because I think Anthony may be coming back to this point.
Yeah, thank you. So looking at the strengths and limitations of this trial, so firstly, it was a very well-designed trial. It was a large trial, had minimal bias with their randomization. The recruitment was prospective, and there was minimal loss in terms of their follow-up, so almost less than 10%. In terms of the limitations, we briefly talked about this earlier on, was that blinding of the trial was of course not possible at the bedside, but the follow-up examiners were unaware of the treatment assignments. And this is really from an ethical standpoint, is that they wouldn't be able to withhold any non-algorithmic transfusions if the infant had extenuating circumstances. So which meant that there was an imbalanced violation rate, especially in the higher hemoglobin threshold, but the overall rate was very low. And it didn't really preclude a good between group separation in the mean hemoglobin levels. Another point that I wanted to highlight was that this was a very large trial and it was performed at multiple centers all over the States. And they used blood banks at different centers. And of course, each blood bank was unique in terms of its practices. So perhaps it might not be possible to really generalize all of the results from that. And one would argue that it might be impossible to actually use a single blood bank to get all their blood transfusions from. But likely that when you do have this clinical variation, it meant that perhaps it makes the results from the article much more generalizable because it was done from all over the States.
So Dr. Patel, a question for you. I think this is a good time to bring about the type of blood we use for blood transfusion, and a lot of data, both from the basic science animal models and human studies, at least from the adults, is coming. Would you like to comment on the type of blood transfusions?
Sure, yeah, Viral. I think this trial is, when do you transfuse? And I think that there's a separate question of what do you transfuse, where I think we have less data. There's been a lot of interest in the adult blood banking community about whether fresher blood yields better outcomes. And despite preclinical data suggesting that fresher blood might be better in terms of biologic parameters, almost all of the trials have actually not shown any benefit in any clinical outcome with the use of fresher blood, including one that was done in preterm infants, the repeat trial. So I think so far there's nothing convincing to say we should be using only fresher blood for transfusion with a lower storage duration. Some of the other factors are kind of uncertain in terms of irradiation, which varies. Some countries don't routinely irradiate red cells. That's more common here in the US. And storage solutions also vary by blood centers and blood suppliers. And I think those are all kind of uncertainties, but I would put that as a different question about what are we transfusing as opposed to when are we transfusing, which is, I think, the question that the top trial answers. And the last one is about actually the donors themselves. And is there something about the donors, for example, the age of the donor, the sex of the blood donors, that might influence the effects of the red cells being transfused? And I think those are all uncertainties in at least the field of transfusion medicine.
Thank you, Dr. Patel.
Thank you. So finally, in terms of the discussion, as well as registration, protocol, and funding, the trial met all of the checklist items as per the 2010 checklist. So having reviewed this article and discussed it in detail, it would be interesting to talk to the moderators as well as the audience, and then talking a little bit more about, what are our next steps? So key questions that I thought that perhaps we could talk about during our discussion is that, should we encourage restrictive transfusion practices in place where it may not be in place? And should we consider these restrictive practices, especially at a time during pandemic where there has been a huge shortage of blood transfusions as well? Yes, Dr. Harish.
Anthi, first of all, thank you very much for a very comprehensive and very thorough sort of look at this. I would say that, again, the restrictive, so long as we're within the boundary of where we have evidence, that is the cutoff levels of the top trial, I think it would be a good idea. And I think just to highlight the fact that the imbalance in violation of the protocol was that clinicians who had a baby who was randomized to the low arm tended to violate that because I think somehow we all, quotes, want to do something, as Dr. Silman used to say. And also, we have a bias that giving more blood with more oxygen carrying capacity must in some way be better. But I don't think that we have proven this. But I think it may still be a way for clinicians to emphasize to those who still have the bias, look, the data doesn't show any difference if you stay within those limits.
And I would just add, this is a great opportunity for trainees and early career neonatologists to ask in your unit, is there a transfusion guideline? And if there's not, this two long-awaited trials that I think both are very consistent, I think this might be a great opportunity for somebody to take this on with potentially a faculty mentor and develop guidelines to use, because there's always this issue of evidence actually reaching the baby at the bedside and translating this evidence into routine practice. And I think this is one of those opportunities where we've been waiting for this information for a long time. We have it, and I think let's make use of it in terms of translating this available evidence into our routine care. And one strategy would be to implement guidelines or develop guidelines for many of the NICUs that don't have them currently.
I very much echo that remark, Ravi. I guess another issue, Anthony, is where should the field go? I don't know if you have any thoughts about that.
I think especially having analyzed all the different trials, whether it's your Iowa trials, you have your TOP, as well as your Pint trials. So giving, there is one way of kind of interpreting evidence from the data and then practicing that at the bedside. So the data from the randomized control trial does show there is no significant difference. And it's really interesting because, especially from a practical standpoint, especially with a pandemic, we often get multiple emails talking about, there's a huge shortage of transfusions, whether it's red blood cell, platelets, FFP, and it really makes you wonder and think about, well, does this infant really need this transfusion when there's been an incredibly robust randomized control trial that has shown there's a statistical significant difference? So from an academic standpoint, yes, one could say that perhaps not, but I can also appreciate how it would be difficult for a physician to be at the bedside and seeing the infant becoming hypoxic or profoundly septic. And in those cases, having those extenuating circumstances does mean that perhaps one would qualify for a transfusion from a clinical standpoint.
Yeah, and to build on that, I mean, perhaps one thing that we can move beyond is to go back to what Dahlman and people in the 70s and 80s and then 90s and 2000s have all been arguing for, which is an individualization. Right. So and think that we're on the cusp of being able to look at this. There's a review article by Chad Anderson in Pediatrics talking about supply and demand of cerebral oxygen. But I think the whole field is waiting with anxious and bated breath for the results of the Danish led European Safe Boost C study. Essentially, can we individualize cerebral oxygen needs and cardiac output and the delivery of oxygen with some sort of proxy for consumption in the brain? Can we actually individualize it? That's probably where the next energy is going to be consumed over the next 15 years, 20 years. I hope it's actually 5 to 10, but my own experience in the blood doesn't lead me to be that optimistic.
So I think this is a good time now to address the elephant in the room about NEC and transfusion. We now have a lot of animal data, especially coming from Dr. Maheshwari's lab, but it's more about the lower value than the number of transfusions. So Ravi, do you want to elaborate on that, where we stand currently, or is our fear of transfusion-associated neck not exactly holds true?
Yeah, I mean, I would take it as even in an area where I still would say from a scientific perspective, I think there's some uncertainties. You always have to walk your way up to the top of the evidence pyramid. And I think what Antti very nicely presented is what we have today as the best available evidence. And I would say that the best available evidence suggests that a more restrictive approach to transfusions compared to more liberal doesn't increase neck within the specific threshold studied in the top trial. I would be more cautious and concerned about going lower. I think this idea of how low can we go, that would be something I think somebody would have to show the safety of that. The challenge is that a hemoglobin doesn't equate to sufficiency of oxygen delivery, to Horatia's point. And I do think that is where there needs to be a little bit more for any given hemoglobin. What's the level of tissue oxygenation in, for example, the gut? And also what effects anemia might have that on kind of gut injury that probably rely on other factors in addition to just the hemoglobin. So I think that those are things that for scientists may be worth looking at, but for kind of the best available evidence to guide practice, I think you have to go back to these are the types of studies, large trials that are done in many centers that I think we should rely on that in terms of how we should make clinical decisions. That's my thoughts. I'd love to hear what others think.
Harish, you want to comment on that?
Yeah, I mean, as I said, people try to individualize the need for red cell transfusions using all sorts of parameters. In Glasgow, they were trying to use available oxygen, which was a laboratory test to see how much a sample of blood from a baby could release oxygen. Obviously, that's cumbersome. People have looked at things like VEGF levels. Nothing really has panned out. And hemoglobin is still a relatively simple thing for the clinician to reach out to. And I think it's going to stand the test of time, particularly in under-resourced settings. For the more resource intensive, shall we say, well-off places, I think the field does have to really evaluate new technologies. But I would argue, and this is perhaps my own bias, there tends to be an overabundance of acceptance of new technology simply because it's new. And I'm going to put my foot where my mouth is and say bedside echo has still not really been adequately tested in my view. Here with neuroscopy, ever since John Wyatt in University College Hospital first described it in around about 1986, I think that there's been a very different approach. There's been a very measured, evidence-based approach. And I very much applaud Dr. Grierson's and the Europeans' approach to really see if it actually makes a difference. If it does, then I think using the results of their trial, one way or the other, that trial can't go wrong. If it shows benefit, it has proven something useful. If it doesn't show benefit, it's taken away a whole series of things that people want to add in to the NICU. So I think it's a very pivotal trial that's coming our way. And we really do need to then, if that doesn't work, just simply go back to hemoglobin for the short term anyway.
So I have a few audience questions to go through. So first question for both you, Ravi and Harish, is this wasn't a non-inferiority trial. So isn't it difficult to say that restrictive is better than liberal?
But this wasn't a non-inferiority trial. this was set out as a superiority trial. With non-inferiority trials, people forget that you need a standard of care comparator. Here, there was no standard of care comparator. There was a range.
Ravi, do you have any comments on that?
I guess I would go back to saying, for the skeptic who would say, well, it's not harmful to give more red cell transfusions, the outcomes are about the same. The question would be, why would you do that? What's the benefit of giving more red cell transfusions if you're not actually achieving any improvement in the clinical endpoint? And in that sense, I think that most clinicians would probably say that, the use of this data would be to support more restrictive approaches consistent with the lower threshold.
Can I just add to what Ravi just said? I said earlier that one of the reasons I started puddling around in this area was I just got tired on ward rounds of people incessantly arguing on physiological grounds that one or the other, when there was no actual data. It was just tiresome, and one had to do the trial. But there was also one other thing. I lived through the HIV transmission era, and I vividly remember a baby that I am quite sure in Toronto at Hospital for Sick Children, that one of our group, including me, I can't tell who did the transfusion, likely, and I can't prove it, likely gave that baby HIV. Now, after that, HIV testing, as Anthony pointed out, has become incredibly safe. And Dr. Lubin's efforts in this arena are just magnificent. And the risks are very low. But exotica, like Chagas disease, Nile Valley, there's always something coming along. And I think in these pandemic days, I don't think it's easy to overlook that. So don't lightly give a blood transfusion, is Ravi's point, and I firmly agree with that.
So one last question before we wrap up the session from the audience. Dr. Raplani, did you find any sex differences in your results in the study?
All of the analyses were adjusted by gender, so we didn't. Now, there's always a problem in doing pragmatic trials. Doing large trials, I mean, it's taken 20 years to get from when we first conceived Pint to top. So you can see it's not a simple pathway, but you have to get people to buy in. And part of that means that you don't get all the data you want. We desperately wanted the gender of the donor because there was evidence from the SHOT study in Britain that there may be an impact on things like Charlie. So for the recipient, that is the baby, we didn't show any effect. We do not know about donor.
And I think there's one last question, sorry for that. And the question is, there's some practice variations that some clinicians use high hemoglobin value for PDA conservative management to overcome stealing effects. Is there any physiological reasoning or evidence-based reasoning behind it to keep a higher value for PDA management?
Well, no, there isn't. Frankly, I think the whole field of the PDA, I mean, I've lived through, I can say this safely since I've retired now, I've lived through several pendulum swings on PDAs. You know, we are so good collectively. That's why we're in ICU, at finding a physiological rationale for doing virtually anything that moves your bias needle. And the PDA is certainly one of those. And the results of the OSCAR trial confirmed the very large observational studies coming out now that, you know, if you have a PDA, you may not benefit from trying to close it.
Cool. That was very informative. So thank you so much, Dr. Kriplani. Your trial probably answered the long-standing question of what values should transfer on. And I think, as Ravi pointed out, the future clinicians and trialists should focus on the type of transfusion rather than the values as such. So thank you everyone for joining in. Our next sessions will be scheduled in March for the part 2 of it, and we'll send the further details through the TCAN listserv. Thank you all for coming. Thank you, Ravi, and thank you, Harish, for the excellent mentoring. And Anthi, it was a great presentation. Everyone loved it.
Thank you.
Thank you.
Thank you and great job, Janti.
Thank you.